Thank you. Thank you. Let me start by, of course, thanking the organizer for this opportunity of giving this talk about HIV and aging, and I will try to talk a bit about the data we have from Sub-Saharan Africa. This is my disclosure slide. So improved survival and the achievement of the 90 or 95 goals is actually resulting in a decrease in mortality and decrease in opportunistic infection. And so what we are actually facing now is the surfacing of non-communicable diseases as a main issue in people living with HIV, especially in those people who are on long-term antiretroviral treatment and also older age. We are also observing an increased longevity with increasing numbers of older people living with HIV, with emerging geriatric syndromes and need for specialized geriatric care. So I think it's time that we see as a priority to find a way to promote healthy aging in people living with HIV. And healthy aging is maintaining the functional, physical, psychological, cognitive ability to maintain independency. And I would really hope that this will become the fourth 90 target for older people living with HIV, maintaining independency. So what is older? People cannot really agree on what is the cutoff for becoming old, because of course aging is a continuous process. So sometimes aging is just decided on basis of things like retirement, insurance, and the UN cutoff is 60. However, there has been really a suggestion of considering people living with HIV becoming old at 50. And the reason for this cutoff, it seems that people older than 50 have actually reduced immunity response to antiretroviral treatment compared to younger people. There is an increased risk of death. There is an increased risk of comorbidities. There is an increased risk of polypharmacy, although this may not be so common in Sub-Saharan Africa. And also, there is an early onset of geriatric syndromes, and particularly frailty. I will talk a bit more about frailty later. So these are the estimates of people living with HIV in the world over 50. And these are proportions. And you can actually expect that in countries like North America and Europe, that is the blue line, the proportion of people living with HIV over 50 is really higher compared to other countries. That is over the total of the people living with HIV. And so the question is, why should we actually worry about older people in Sub-Saharan Africa, where we know our population is generally very young? And I hope by the end of this section, I will be able to convince you that it is really time to put resources for both research and clinical care. So these estimates refer to the proportion. However, when you look at the absolute numbers, the upper figure shows low-income countries versus rich countries. And you can see that when you look at the absolute number, actually low and mid-goal income countries have the majority in terms of number of people that are aging with HIV, so over 50. Now, if you look at the lower figure, this is actually showing absolute number of people over 50 in the WHO regions. And the first region with the highest number, it is actually Eastern and Southern Africa, where we are almost hitting 3 million people that are over 50 years and living with HIV. So what are the health concerns in older people that are different from younger people? And I'm just talking older, not necessarily with HIV. So some factors can actually trigger non-communicable diseases and geriatric syndromes like frailty. And these are some factors like age, sex, human race, so genetics, but mostly they are actually modifiable factors like your diet, physical activity, and smoking. So all of these can put you at risk of non-communicable diseases and frailty when you're aging. Non-communicable diseases, in turn, can actually put people at risk of polypharmacy because they are prescribed multiple drugs. And the risk coming with polypharmacy is really adverse drug reaction, but also potentially inappropriate medications. Polypharmacy, in turn, can trigger frailty, but frailty also can trigger polypharmacy. Now, what happens when we actually throw HIV in the middle? So HIV magnifies all these problems because HIV itself, it is actually a risk factor for non-communicable diseases. For polypharmacy, because they are already medicated for HIV and maybe co-infections, and also it's a risk factor for frailty. So let me start talking just a bit more about NCDs and saying that people living with HIV are actually a threefold risk to have non-communicable diseases. And this is due to different reasons. One is chronic inflammation. Two could be the sequelae of opportunistic infections. For example, imagine lung disease post-tuberculosis. Another reason is long-term exposure to antiretroviral treatment, and you can think about, for example, renal disease and tenofovir. And then there is now an increased risk that is associated with people living longer. And then you have to add all the other known factors that put people at risk of non-communicable diseases, like age, sex, family history, urbanization, that is actually happening in Africa, and then overweight and obesity, and also physical inactivity. So how actually does chronic inflammation lead eventually to non-communicable diseases? So it is actually very complex, and I will not go into the details because I'm also personally just a clinician. But what I want to emphasize out of this figure is that it actually starts during the acute phase of HIV infections, so days and weeks after someone acquires HIV. And it is led by HIV replication, but also breach of the intestinal mucosa, and of course also the translocation from the breached intestinal mucosa. So what happens with all of this happening is that there is a sort of immune perturbance, and that is also causing activation or dysfunction of cells that are normally involved, in immune activation. And so this now happens very early, and then that just becomes chronic. And then it goes on for months and years, and until someone actually lives with HIV. So the bad news is that as much as antiretroviral treatment can partly modulate this, it cannot actually reverse chronic inflammation. And so, of course, it's good that people are put on ART because it reduces this inflammation, but it doesn't nullify it. And so even people on successful ART actually have chronic inflammation. And this again translates in all the possible non-communicable diseases you can think about. So, for example, cardiovascular diseases, but also kidney dysfunction, liver dysfunction, and so on. This is actually a study that was done in Denmark and followed up. It's actually, the data is actually extracted from the National Medical Register, where they look at people living with HIV, and they also looked at controls, 10 per case. And they followed up people for 10 years. So on the left side, you can see the comparison of non-communicable diseases between HIV uninfected and people living with HIV by age. If you look at the green line shows people with no NCDs. And you can see that for all patients, but also for all ages, this line is persistently lower, therefore there are less people free of NCDs as compared to people without HIV. And so that starts at a very young age. Even in the group below 30, you can see that difference. I found also very interesting the figure on the right, figure B, because in this figure, people are not stratified by age, but what I would call like antiretroviral treatment era. So 1986-95, this is pre-ART, or pre-triple treatment. And then 95, 2005, was triple treatment with probably more complex regimen, more toxics, and probably less also efficacious. And then the last decade. So again, what you see is that there is not a big difference in in non-communicable diseases between the HIV positive and HIV negative participants. And even within the people living with HIV, actually there was only a slight reduction of non-communicable diseases, even when potent ART was introduced. So these are data from low and middle income countries. It's a meta-analysis. It is actually not very new, but just for you to know that if hypertension is common, I just picked some. Hypertension is common at 21%, dyslipidemia at 72.5%, overweight and obese we have 27.3%. When it comes to data from Sub-Saharan Africa, I try to do a literature review, but it is almost impossible to pull data together. There is, first of all, NCDs are not systematically screened or documented. Some studies are multi-countries, some are from one site, the results are even conflicting, and there is no longitudinal studies informing long-term outcomes. This is a study that I bumped into from Sub-Saharan Africa, but it's a single center. I wanted to see the outcome, and this study suggests that people living with HIV has better outcome in terms of control of blood pressure and also glucose than people without HIV. However, as I said, this is a single study. Yesterday I saw a poster, I think it's 144, that shows exactly the opposite. So what I'm trying to say is that we really don't have enough data to draw any conclusion, even on the prevalence and the outcome of NCDs from our continent. Let me quickly now switch more focusing on aging and frailty. Frailty is defined as a syndrome of physiological decline in late life, characterized by vulnerability to adverse health outcomes. And so frail older people are less able to cope and adapt to stressors such as acute illness and trauma, or even surgery, for example, than younger people or people without frailty. And it's part of comprehensive geriatric assessment, and it actually predicts survival and disability-free years better than comorbidities. So I mentioned frailty is a geriatric syndrome. Geriatric syndromes are conditions that cross organ systems and disciplines in older people. They are multifactorial, they share risk factors, and also mechanisms. Physical frailty is generally described using 5 criteria, which are shrinking, becoming weak, poor endurance and energy, being slow, low physical activity. And actually, HIV, it is an independent risk factor for frailty, with a prevalence in all people living with HIV from 5% to 29%. In the figure, I'm trying to show the mechanism that can lead to geriatric syndromes and frailty. These include age, cognitive impairment, functional impairment, reduced mobility. What I think you need to take out of this figure is that there are actually kind of vicious cycles where these risk factors cause frailty and geriatric syndrome. And then frailty and geriatric syndrome, they actually magnify back these factors. Like, for example, if you are frail, you tend to move less, so you have reduced mobility, but reduced mobility is also a risk factor for frailty. And so once you enter that circle, it's actually very difficult to come out. And geriatric syndrome and frailty, they are actually predisposed for negative outcomes, such as dependence, disability, hospitalization, and death. These slides shows frailty and healthy status in people living with HIV and people without in the process of aging, with the red line indicating people living with HIV. So even in early age, you can see that level of frailty or healthy status in people living with HIV is as expected lower than people that are HIV-free. However, what is interesting to note is that in the late 40s and 50s, these lines are not parallel anymore. And so what happens is that people living with HIV tend to become frail earlier and faster, and so disabled. And there is actually, you can see, while this condition is usually common in people living without HIV in their 80s and 90s, when we are talking about people with HIV, we are seeing frailty in people that are 50 and 60. So this is what it is, the hypothesis of the pathway to frailty. It is actually not very different from what we're seeing with NCDs because it all starts with chronic inflammation. So there are underlying factors that are also present in people without HIV at molecular level, comorbidities, and also from the environment. HIV infection and ART magnify these factors. And that actually, again, can cause inflammation, immune activation, also endocrine dysregulation, and that again can cause all these other sorts of conditions like, just for example, anorexia, insulin resistance, and then this translates in the clinical findings that are characteristic of frailty and therefore in negative outcomes. I don't want to go into the detail on how to measure frailty, it's rather specialistic, but I want to simply draw your attention to the fact that a different school of thoughts here among geriatricians. And so when you read a paper that talks about frailty, go and check what tool was measured. So the tools are really many, but when it comes down really in classifying frailty, there are two school of thoughts. One is looking at what is called the frailty model or frailty phenotype, which is what I already described for you. That is, for example, weight loss and weakness, and there are particularly way of measuring that with particularly cutoff. So, for example, weakness, you need to measure grip strength, and there are really cutoffs to determine who is robust, who is pre-frail, and who is frail. And then there is the frailty index. The frailty index is looking at frailty in a completely different way, which is an accumulation of clinical deficits. For example, loss of hearing. There are at least 40 that you are going to assess. And then you reach a kind of index by using that. So what I'm trying to say is that because we can't agree on what actually, not only we can't agree, people are fighting on which one is a better way of looking at frailty, you almost never can compare two different papers because maybe they use a different cutoff to determine who's old, and then they went on to determine a different way of looking at frailty. And so just pay attention to that when you are reading a frailty paper because it makes a big difference. So about frailty and geriatric syndrome, there are very few African studies, and again, people could not agree on which age to look at. Some studies, they looked at the entire population living with HIV, other they looked cutoff, for example, of 60, other of 50. And so what you have are all these numbers, like 19%, 7%, but you can't really, again, draw any conclusion. And for some studies, it's not even very clear how frailty was measured. Factors that were found associated with frailty in Sub-Saharan Africa are age, female gender, low education, living alone, low body mass index, depression, and low CD4 count. Actually, they are very similar to what is actually found in other settings, except for the gender, and I will tell you just in my next slide why. So I tried to do a comparison that is a bit, I admit, to compare like tomatoes with apples or something like that, but I really wanted to. I found a cohort where they described several geriatric syndromes from the US, and then I have my cohort in Kampala, and I wanted just to see if we really see something completely different. The American cohort, people were younger at 57, and Kampala cohort, they were actually older at 67. But I would say that the most frequent observed geriatric syndrome are very similar. The most common condition is actually pre-frailty. in both, and then cognitive impairment is also very prevalent in both cohorts. In the KAMPALA cohort is really high, more than 70%, but we also think you're probably using the wrong tool. Well, the tool that was used was the same, but we think the tool we are using is not the right tool for Uganda. And then what I wanted also to mention to you here, look at the percentage of men in the different cohorts. So most of the men, most in the Western cohort are men, 97%. So they cannot do comparison between male and female. I know my time is up, so these are my conclusions. So the number of older people living with HIV is really growing in Sub-Saharan Africa, but we don't have data on NCDs and geriatric syndromes for appropriate programming. We have no longitudinal data about outcomes. We also need to develop and adapt some of the tools. We need to simplify them. Geriatric assessment is really long. In my cohort, we take between 2 and 3 hours per patient. This is not possible in routine settings. And there is also need really for training healthcare workers on the approach for older people living with HIV. And with this, I really would like to acknowledge and thank EDCTP, because part of my work is actually funded through a senior fellowship. Of course, our international mentors and collaborators and the team in KAMPALA. And I also pleased to announce that this morning, we were only 5 of us, but we were very happy to start what we have called the HIV and healthy aging in Africa working group. And so I would like again to thank the interest organizers to giving us an opportunity of all being here to start this group. Thank you.